everyone. I'm Kevin Parvaresh. It's nice to be here talking to you, and thank you so much for tuning in. I'm coming to you from the OSI Medical Group as part of HOAG, and I'm here today to talk to you about hip arthroscopy and hip preservation surgery. Before I delve into that, I would like to tell you a little bit about myself. I originally am from Southern California. I grew up in San Diego. I enjoyed surfing and looking at the beaches and spending all my time outdoors. I then decided to go across the country to get a different perspective and did my undergraduate over at Georgetown University. I love DC and stayed there for medical school, and then returned here to sunny California to do my residency at University of California, San Diego. I then decided to complete my training in the Midwest, where I did a sports fellowship, part of which was hip preservation at Rush University in Chicago. And thankfully I'm back here in sunny California, enjoying the beaches and taking care of patients like you every day. So now I'd like to turn to the talk, and we're going to work through this, and I'd be happy to take any questions at the end. So the talk is on hip arthroscopy and hip preservation surgery. Just to let you know, I have no relevant disclosures for this talk. However, there are some graphic images of the surgeries I do that are included. If you feel like those are inappropriate, I would just refrain from watching those sections, and I'll let you know. Those are at the very end. As part of the overview, I thought it'd be best to talk to you from a patient perspective, so I'll go through some anatomy and pathology to give a background and education on hip preservation surgery. I'll then move to how typical injuries present themselves, followed by a section on the imaging that we use in the clinic to work up these diagnoses, and finally move to the different types of treatment that we can offer. I'll start inside out with the anatomy, working from the joint itself out to the structures around the joint. The structures in the joint we would say are intra-articular, and these include the cartilage, labrum, ligaments, and potential spaces. The labrum is a structure that surrounds the hip joint. It's almost 360 degrees. This acts to both increase the depth of the socket as well as improve the stability of the joint itself. The cartilage is the inner lining of the joint. This is on both the ball, which is the femoral head, as well as the socket, which is the acetabulum, and this surrounds the entire joint. The ligamentum teres is a structure that's in the center of the joint, connecting the two. This improves both stability and actually, when we're younger, has a main nutrient artery to the femoral head. And the final section is this subspinal space. The spine is a portion of the pelvis that lies just above the femoral head. And there's a little recess in between the labrum and the capsule there that we call the subspinal space. And it's something that can be both injured in terms of pathology and also utilized in terms of our surgical reconstruction. Moving outwards, we have the capsule that surrounds the joint. This is comprised of three main ligaments, the biggest of which is called the iliofemoral ligament. It's named for the two bones that it connects. It looks like an inverted Y, and it's in the front and the top as we see here. And this is the strongest of all the ligaments. And in fact, if you look on the top right of the slide, the top right corner is where that iliofemoral ligament is, and the larger section relates to the thickness of the ligament there. And as we can see, it's nearly 5 to 6 millimeters thick, whereas the other two ligaments are around 1, 2, or 3 millimeters thick. The others are the pubofemoral ligament, which is more inferior, and then the ischiofemoral ligament, which is posterior. Continuing to move outwards, we then look at some of the neuromuscular structures. The largest muscle group in the hip are the gluteal muscles. These include the maximus, medius, and the minimus. On this illustration, you can see the maximus has been recessed, the medius is partially recessed, and the minimus is underneath all those. And these are important hip abductors and hip extensors in terms of mobility of the hip joint. Moving more inferior, we can also see the piriformis muscle, the sciatic nerve, which runs in the back of the hip joint, a number of short external rotator muscles, and then muscles further down the leg that are also important in hip anatomy. So that's just the basics of some anatomy, and then we'll move to just kind of a discussion of some injuries that can occur at all those different spots. I like to think of the pathology in terms of where pain or discomfort typically presents. And so this can be broken down into the anterior or front of the hip, the lateral or side of the hip, and posterior or back of the hip. In the front of the hip, we can have tearing of the labrum, which remember is the surrounding the hip joint. That can cause both pain and instability of the hip. Of course, we can have fractures, which are breaks in the bones. This can occur both in the ball and the socket or further down the leg. Bursitis, which is inflammation of the potential spaces in the hip joint. This can be both in the front of the hip with the iliopsoas or hip flexor muscle, as well as you can see in the lateral side of the hip over the greater trochanter where some of those gluteal muscles insert. The next thing is a sports hernia. We didn't talk too much about the anatomy of the front of the hip, but in fact there's a number of muscles that attach there, and this is actually a misnomer. Typically there's not a true herniation of any bowel that goes through this, but in fact it's a tear in some of the connective tissue or tendons in the muscles in the front of the pelvis, and this can manifest as significant pain both at rest and with function. And finally, another common presenting pathological entity is hip arthritis, which is degradation or wear of the cartilage surface. Moving to the lateral part of the hip, we did talk about bursitis. There's also tendinopathy, which is essentially inflammation or tearing of the tendons that attach to the lateral side, such as the gluteal tendons. And then neuralgia, which is a fancy term for any inflammation of the sciatic nerve or the smaller nerves that surround the hip joint. This typically is more of a burning or numbness or weakness problem than necessarily pain-related, but certainly could be associated with pain as well. And then finally, moving to the back of the hip, there's actually a number of different pathological entities that can present with posterior hip pain, and some of them may actually be structures that are further away from the hip that simply get referred pain, such as the lumbar spine, the sacroiliac joint, which is in the back connecting the pelvis to the spine, the piriformis muscle, which can also put compression on the sciatic nerve, and the ischium, which is where the hamstrings attach. This is also called the sits bone, where people have trouble with pain in the back when they're seated. Moving on to how these can present, there's really a large way that all these can present, numerous different fashions, different types of feelings or sensations that one might get at certain times. And I like to break it down in terms of three main components, which are in terms of the function that you feel this. So this is just at rest if you're feeling any pain, discomfort, numbness, weakness, or aching. And that can really be descriptive of something that is a chronic in nature or something that is really new but is really persistent. And so that's something that we can decide and determine based on how patients talk to me in clinic. The second thing is how they would present in terms of my exam. So whether in certain motions these seem to cause the patient's pain, whether it's provocative or at rest, if there's certain areas that are particularly tender or other muscles that are weak. And this can be included as part of the presentation in terms of keying everything together. The last thing is function, and that's a descriptive term in terms of when there's a sensation that something's not right when you're moving, when you're doing a particular sport or particular activity. And so we take all these things together in determining what the possible diagnosis or diagnoses may be to help us really define what it is that is the problem and how directly we can assess that to help you. So as we take that presentation, we also look at some defining factors both in terms of the anatomy as well as the pathology, and this is typically assessed with imaging. The three main imaging modalities are X-rays, MRIs, and CT scan, and all of them are very valuable in the assessment, and not all of them are necessary at all times, but they certainly add different perspectives, as we'll see on the next few slides. So starting with x-rays, straightforward x-rays are a great way that we can assess the global perspective of the joint. Typically, we look at the head and the neck, and we can see here two very different examples. On the left, we see a severely arthritic hip, and on the right, we see a relatively normal hip with good joint space. Typically, we'll look at the space on the superior part of the hip because that's the weight-bearing region, and normally we would see anywhere from 3 to 4 millimeters of a gap there. That gap actually represents cartilage, but we can't see the cartilage on the x-ray. On the x-ray, we just see the calcifications. Certainly on x-rays, we would see any fractures or other bony abnormalities as well, and so they are a very good starting point for us to build our understanding of what's going on. This is a side view, and this is particular for one pathology called hip impingement, or femoral acetabular impingement, named FAI. It's a measurement of what we call the alpha angle, and the alpha angle represents how spherical this femoral head is. On the bottom, we can see the femoral head is a perfect sphere, whereas on the top, the femoral head is almost a square. And so we measure the angle from the neck to where that circle becomes a square. Normally, we'd measure about 42 degrees, though in patients that have significant hip impingement, these measurements can be greater than 60 degrees, which can contribute to severe pain and dysfunction of the hip. Other values we can get from looking at both hips. We kind of look at how the socket is formed, whether it's shallow or deep, if it's upsloping or not. We also look at the inner and the outer tables of the pelvis to see if there's any pathology there. We can see how the pelvis is rotated, whether the cup is pointing forward, pointing backward, and this can all contribute to different terms of pathology. Moving to MRI, this gives us a much better picture of the soft tissue structures, which were invisible on the x-ray. In particular, we look at the cartilage, tendons, and muscles on these views. This is a description of a labral tear. We can see on the left a cross-section and on the right a side view, both showing where the labrum has been torn off its attachment to the acetabulum at that cartilage junction. Speaking of cartilage, MRI is also particularly helpful in looking at any damage to the cartilage. On the left here, we can actually see some delamination where the cartilage is starting to come off of the bone. There's also some white signal, which is typically inflammation or swelling of the bone around that area. And on the right, we actually see loss of cartilage with something that we would call a subchondral cyst. This is basically where there's a fissure in the bone of the joint, and then the joint fluid goes into that fissure and forms a small cyst. This can cause weakness of the bone as well as pain in the hip joint, and is typically associated with arthritis. Looking further around the joint, we can also see where some of those tendons attach. This is particular to the back of the hip, the ischium, where the hamstring tendons originate. And here we can actually see a near full thickness tear of those hamstring tendons coming off of the bone. That white is fluid signal, which signals inflammation of that area as well. And then finally, moving to CT scan, although this is particular for bony anatomy, this gives us really a good 3D understanding of how the hip looks morphologically. So we can look at the 2D images on x-ray, but then extrapolate them here with 3D imaging to get a full understanding of how that joint looks circumferentially, up and down, left and right, and really get a full understanding of how those bones form. So with that in mind, we're moving to different treatment options that we might offer for hip preservation surgery. And the real key to treatment is to match how the presentation is with the imaging. There are certainly a number of imaging findings that may be incidental, and those may or may not be related to the current pathology and symptoms that you may be experiencing. And so the real art of this is to match how that represents based on what we know for presentation and what we know for imaging in terms of how we can directly impact the disease and help you feel better. I like to think of treatment as a spectrum. On the left, we typically start with non-operative treatments that are very safe. On the right, there are operative treatments. In certain instances, operative treatments may be best, and in certain instances, non-operative treatments may be best. And it's really dependent on individual presentation as well as the pathology. So on the left, you have the most basic things, which is to modify activity, limit impact exercises. We can then bump that up to adding anti-inflammatory medications such as ibuprofen, Aleve, and those sorts of things that can be taken intermittently to assist with pain reduction and inflammation. We can also look at physical therapy as a possible means of not only assessing static but also dynamic muscle imbalances, fatigue, and any bursitis that can be worked on with a number of modalities that can directly improve pain. Moving to more invasive things, we can do differential injections. Injections include a variety of substances such as cortisone, PRP, and stem cells that may be indicated in certain patients that can help both heal and improve pain and discomfort around the hip joint. And finally, there are instances where we can recommend surgical management for repair, fixation, or hip preservation in terms of prolonging the health of the native hip joint. I'll talk about 3 particular treatments in general, although there are certainly more. I thought these are pretty much the most common and might be the most educational for you. The first is hip arthroscopy. This typically treats hip impingement, or FAI, as I mentioned before, addressing both the labral tear as well as that large cam lesion that we'd seen on the x-ray. So here we can see on the left the labral tear. This is a metallic needle that we're putting in the hip joint to denote that, the labrum being on the top and the cartilage being underneath. In the center picture, we can see anchors with sutures that have been tied against the labrum to suck that back down onto the bone and to assist with healing. And then on the far right side, we can see the labral repair atop, but then also we can see we've smoothed down that extra bump that was on the femur before. And this really is a comprehensive correction of impingement, which both prevents it from deteriorating as well as repairs the labral tear that we'd seen on the MRI. Another surgery, which is hamstring repair, and just a disclaimer, this is where some surgical pictures may be a bit intense for some people. But here we can see the hamstring muscles which attach to the back of the hip joint along the ischium. These are called the semimembranosus, semitendinosus, and the biceps. And these can actually tear from their attachment, or they can tear where the muscle attaches to the tendon. Typically when they tear from their attachment, if they haven't moved very far, we can treat this without surgery, but if they're significantly displaced or if there's a large gap between the tendon and the bone, we would recommend surgical fixation, both in terms of rehabilitation and maintenance of strength in the future. This can actually be performed both minimally invasively with arthroscopic surgery as well as with open surgery, and it really depends on the patient, the presentation, and the type of tear where we can make that decision. And finally, the third one I would discuss is gluteal repair. This involves repair of the tendons of primarily the medius and the minimus, which tear off the tip of the greater trochanter, which is located on the femur. When these are partial tears, again, these might be managed non-operatively, but even partial tears can often cause a significant amount of hip pain and discomfort. And so we've developed both arthroscopic and open means of addressing this as well, again, depending on the individual pathology, the presentation, and the chronicity of these symptoms. I thought I would touch on rehabilitation. This, of course, is specific to the type of surgery that's performed, but in general, there are 4 phases. The first phase consists of protecting the joint and avoiding irritation in order to let the surgical beds heal. This is typically about 6 weeks in length. Simultaneously with this, as healing increases, we progress patients to normal gait in concert with their therapist as well as us in the office. And this typically happens over 3 to 10 weeks after surgery. The third phase is returning patients to pre-injury level of function. This is typically weeks 8 to 16 with more functional movements and strength training. And finally, in phase 4, we return patients to running and sports, and this is typically the 16 to 32 week mark. When we looked specifically at return to sport, we've done a number of studies. This is a study on sport-specific function, looking at patients before surgery, 1 year, and 2 years after surgery. And what we found is that there are actually 4 groups of recovery. There's patients that progress very early and continue to progress thereafter. There are patients that steadily progress over time, patients that actually progress later beyond a year, likely due to the chronicity of their symptoms and the debilitation in terms of their muscle balance that needs to be worked through with physical therapy. And unfortunately, there is a group of late regressors which likely have too severe pathology and do not necessarily improve, although thankfully this is a very small group and is in the minority of patients. So with that, I'll put my contact information here. I'd love to hear from you. I would take any questions. And just to let you know, I am also very interested in research, evidence-based medicine, and looking at the ways to improve patient outcomes. So if you do have any interest or know of anyone that has interest to that extent, we have a research foundation, and I'd be happy to collaborate on any projects thereafter.
Okay, first question is, what is the typical time frame to return back to work?
Okay, so we've got a question from the audience. The question is, what is the typical time frame for return to work after surgery? And I will say it is really dependent on 2 factors. Number 1 being the type of surgery, and number 2 being what the functional requirements are for work. So in patients that typically have desk work or can work from home, it is a relatively rapid recovery for them to get back to work, on the order of a week or 2 in most cases. Patients that have to drive to work, driving actually can take upwards of 4 to 6 weeks, also depending on the leg that's operated on and the type of vehicle. And then patients that have high demand, heavy labor jobs, we would consider almost as returning to a sport. And so this can take upwards of 3 to 6 months.
Next question, are there any restrictions that may not make a patient a candidate for surgery?
Okay, so the question is, are there any restrictions that may make a patient not a candidate for hip preservation surgery? So this is also a complex question. There are a number of factors that go into making the surgical decision. Part of it depends on the disease severity and the health of the underlying joint, and part of it also depends on the patient's presenting factors and if there are anything modifiable that can be done before surgery. So we take all these into consideration. There's certainly not any patient we would restrict to be seen for consultation. So I would say that we're open to seeing anyone for a discussion of hip preservation surgery and answering questions and educating you on what your potential options are, and if we can't help you, referring you to the right doctor to help with your care. Okay, so with that, there's no more questions. Thank you again all so much for tuning in. I'll look forward to hearing from you and being a part of your community.